In this chapter, we're looking at the immune system. This is helping to protect you, so it's a defense system. It's divided into two initial major divisions, the innate and the adaptive defenses. Helping you to understand how the immune system works, helps you to understand the processes that are occurring within your patient in response to infection, how prevent infection currently and future. So I said that immune system, it's a protective, defensive type of system, and there's two subcomponents, the innate and the adaptive. The innate is non-specific. In other words, it's going to be the response regardless of what the foreign substance is, whether it's pollen, whether it's E. coli. It doesn't matter, the response is going to be the same. It just recognizes something as foreign, and it's a way of protecting you against these non-specific general components. It is further subdivided into two lines, and we'll talk about that in a moment. The adaptive defense system is very specific. It's often referred to as the third line of defense. So it's what is going to respond to a very specific antigen. And so it's a response, say, to E. coli. It's a response to the influenza virus H1N1, and that can distinguish it from H1N2, a different strain of the influenza virus. And so it's very, very specific. The response to ponderosa pine pollen is going to be different than the response to loblolly pine pollen. It can distinguish the differences between very specific antigens. In general, the adaptive defense system is going to take a little bit longer time to be activated than the innate because of the specificity of it. Now, with the immune system, it's more of a functional system, so we don't have an organ system per se. And both the innate and adaptive defenses are interconnected or intertwined. And so initially you'll have the innate defense system be triggered. There's certain pathways, if you will, but it's going to work along with the adaptive defense. So they work together. Very simplified summary is shown in this diagram that the innate defense, you have the first line of defense, which is often like a barrier, so your skin, mucous membranes, and then the second line of defense, if something is able to penetrate beyond those initial barriers, it will involve more internal defenses, things such as involving your phagocytes, your natural killer cells, the inflammatory response, fever, and various proteins that do function in an antimicrobial aspect. The adaptive defense is going to be composed of the humoral immunity, which involves your B cells, your B lymphocytes, and then also your cellular immunity, which involves your T cells or T lymphocytes. So we're going to start with the innate defense system first. This includes that first and second line of defense to try to stop pathogens. Pathogens are disease-causing microorganisms, so it could be bacteria, viruses, fungi. And the purpose is to stop it from attacking your body. That first line of defense is what we refer to as surface barriers. The skin, the mucous membranes, it's an actual physical barrier. Microorganisms would have to penetrate that barrier in order to penetrate deeper inside of you and cause an infection. I often describe your immune system similar to like a chess game or a war game, if you want. If you think of a video game that's a war game, it's kind of like you've got this first line of defense. For the quote-unquote enemy, this pathogen, to penetrate. It has to get past this barrier. So you have ways of protecting yourself. You can't get in me. Well, the pathogens, excuse me, over time have developed different ways that they can sometimes penetrate that physical barrier. They can penetrate and pass through the skin. If they're able to do that, well, now you as the patient, the person, you've got a second line of defense where it's kind of like, ha, you got past that skin. Well, we have a second line of defense here. Then the bacteria kind of like, well, we have a different way of fighting that. And so it's kind of this back and forth. The surface barriers, such as the skin and the mucous membranes, like I say, they're physical barriers. Keratin is resistant to weak acids and bases that's present in the skin. It's fairly resistant to bacterial enzymes and toxins. Now, I will tell you that there are some bacteria that produce a keratinase to break it down. But in general, it's fairly effective. The table here to show this first line defense with the skin, how some of the skin secretions produce, whether it's sweat, whether it's oils, a slightly acidic environment. Bacteria don't like acidic environments. They prefer neutral or a little bit alkaline or basic. And so just lowering the pH a little bit is very effective in inhibiting bacterial growth. With the mucous membranes, like I say, a lot of them, just the consistency of the mucus will help to trap some of the microorganisms, prevent them from penetrating any further. Things like gastric juice is very acidic, once again in the stomach. That's going to kill most organisms that way. So those are examples of some. Now the second line of defense involves more cells and chemical natures. So if something is able to penetrate the skin, maybe you cut yourself. Well, now that's compromised the integrity of the skin, and it allows an avenue or a route of penetration into the body. So now you're going to have to rely upon the second line of defense. Once again, keep in mind this is not specific. It doesn't matter what it is that penetrates. You have certain cells, like your phagocytes, your natural killer cells. You have antimicrobial proteins, fever, and the inflammatory response. In terms of the phagocytes, these are white blood cells. They will ingest and digest, chew up, eat any type of foreign invader. It can distinguish between your cells and anything that is not you. We often refer to as self versus non-self. So anything that it sees as non-self, it will destroy. Neutrophils are one of the types of your white blood cells. They are very effective phagocytes, and so they play a major role in helping to fight infections. Macrophages develop from monocytes, which are another one of your types of leukocytes, white blood cells. They are the chief phagocytic cells, so they're also going to carry out. This is a picture of a macrophage, the large purple substance, and it is basically trying to engulf the bacteria, the small rod-shaped structures that are kind of that greenish color. That is the bacteria. The macrophage is able to distinguish that it's something foreign, so it sends out these extensions from the cytoplasm that draw. It's almost like a tracking beam, if you will, if you watch Star Trek. Those type of shows, it's kind of like, ooh, there it is, latch onto it and pull it in, and then it will phagocytize it, which means it's going to destroy it. It's going to eat it up. Inflammation, this is a response to an injury, and it's a very effective way. Whatever that injury is, maybe you've cut yourself, you've had some type of trauma, maybe heat, maybe chemicals. And what the inflammatory response is going to do, it will increase the blood supply to that area. The benefit of the inflammatory response, and you might initially think, wait a minute, when something gets inflamed, it gets red, it gets painful, it gets swollen, it hurts, how can this be good? The idea behind this response is that it's going to help prevent the spread of any of the possible foreign agents. It's going to help clean up any damaged cell debris there, any pathogens that have been killed. And it also triggers the adaptive immune response. It's a way of turning it on. Hey, we have a potential breach of our perimeter here, and so we need to be on the lookout for any foreign substances, and it also starts the repair. The four main signs of inflammation: redness, heat, swelling, and pain. Sometimes there's a fifth sign, which is impairment of function. So the various stages of the inflammation is going to be the inflammatory chemical release, vasodilation, increased vascular permeability, and the phagocyte mobilization. So in the inflammatory chemical release, what happens is you've had an injury, cut or whatever, and chemicals are going to be released into the extracellular fluid. What this is going to do is trigger or start a whole new type of response. Different receptors are going to recognize this. They're going to release cytokines that's going to help promote and increase inflammation to the area. Now, a lot of these chemicals that are released, histamine is an example, and then you have kinins, prostaglandins, complement. What these are typically going to do is cause vasodilation of the arterioles in that area, and they're all going to make the capillaries extra leaky. That means you're going to be increasing blood flow to the area by making the capillaries leaky. You have more the blood leaking into that interstitial fluid. It's going to attract leukocytes. Some of these chemicals cause what we call positive chemotaxis, meaning it attracts cells to them, specifically the leukocytes. This is for the whole process. Here you can see some of the chemicals that are released, what the physiological effects are. As you can see, a lot of vasodilation. Now, like I said, what happens is with the vasodilation, the leaky capillaries, you're increasing the blood to the area that leads to redness. Remember, blood carries heat with it, so that's going to cause warmth or increased temperature to that area. That increased permeability of the capillaries means you've got that fluid coming in, and that is actually good. It may not feel good to you because you're getting that swelling in the area. That increased swelling, that because of that increased fluid, pushes against the nerve endings, and that's what causes the pain. However, in that fluid, you have clotting factors to help repair the damage. You have antibodies. You are bringing in the phagocytic cells to be able to monitor more closely and look, go on surveillance, looking for foreign substances, clean up the damaged tissue. That also helps to lead to repair. Now, sometimes the pain may also be due to release of toxins from bacteria. That may or may not happen. With the increased fluid, like I said, that leads to the edema or the swelling. One thing that's going to happen, that increased fluid is going to, where does the extra fluid go? It's going to push it into the lymphatic vessels, which eventually goes into the lymph nodes. So it's going to help filter out any foreign material there as well. That can also work, as we'll see in a bit, to help activate the immune system. It's delivering these clotting proteins, as I said, that will help with repair. It also will bring in what we call complement, which is another series of proteins that play a role in fighting potential infection. You start to form, with those clotting factors, form the mesh that acts as a scaffold. You want to try to isolate the pathogen in that area. So if you start forming a mesh around very quickly, It's kind of like, okay, we've had this breach of the perimeter. There's a foreign substance in here. Don't let it penetrate even deeper. You do not want it to get into the circulatory system, because then it can go anywhere in the body and cause even more problems. If you can isolate the area, let's say you cut your finger, if you can isolate potential pathogens just to the finger, it's much easier to treat a very localized infection versus a systemic infection. So I say those phagocytes, the neutrophils are going to come in the area first, and then the macrophages will follow after that. If the inflammation is due to pathogens, then complement, these proteins are going to be activated, and then that's going to help start the whole adaptive immune. So for phagocyte mobilization, first there's release of the neutrophils from the bone marrow. That is leukocytosis. Marginization is when the cells along the capillaries in that inflamed area, they basically release chemicals that kind of grab onto neutrophils, causing them to slow. They're going to cling to the vessel wall, and then they're going to flatten and squeeze between the cells so they can move out of the blood into the interstitial fluid, and that's diabetes. Chemotaxis, as I said, is where the chemical agents attract the neutrophils, draw them towards them. And then the monocytes, as I said, are going to appear later. The monocytes, what we call the cells, those leukocytes, when they're in the blood, when they leave the circulatory system, they mature into the macrophages. Monocytes are going to appear first, and then they will develop into the macrophages. And prior to the arrival of the monocytes, you've got the neutrophils arriving. So this is showing over here an example of what may happen. Yes, I'm trying to pull up a pointer so we can walk through this. So you've had apparently an unlucky day, and you have got a nail that has penetrated and caused an injury here. So here's the skin. What's going to happen is you have these inflammatory chemicals that are being released from these injured cells. They're diffusing. That is what is going to trigger the chemotaxis. So what's going to happen, these little chemicals are being released. Here, the light blue. Neutrophils are going to enter the blood from the bone marrow. And then they're going to stick to the wall. They're going to flatten out, squeeze through. This is going to happen in the capillaries, which are only one cell thick. And then they're going to migrate. How do they know to go up this direction towards the injured site? It's because of the chemotaxis. These chemicals are drawing them there. So this table is showing, excuse me, when you've had that damage, injury to the tissue from whatever cause, you release chemicals, the injured cells do, that are going to be attracting the leukocytes, those neutrophils there. The marginization squeezes through the walls, is attracted towards the cells, and the neutrophils are going to be short-term, macrophages are long-term. They are going to start cleaning up the damaged tissue cells, your damaged tissue cells. They're going to phagocytose the pathogens. Basically, they're attacking and also cleanup group. There may be pus formed. That is the cellular debris that's in the area. Now, some of the release of the inflammatory chemicals, what they are doing is they're causing the arterioles to dilate, so you have increased blood flow to the area. As I said earlier, that leads to the heat and the redness. The heat causes an increase in temperature in that localized area. That increases the metabolic rate of the cells, which is going to increase the rate of repair. Increased capillary permeability means that it's able to leak fluids. So basically, they get leaky. So you have more interstitial fluid that's bringing in more proteins. That's going to increase fluid, push up against the nerves, causing the pain, and the swelling is causing the pain. And the release of all of these inflammatory chemicals is what is attracting the neutrophils, the monocytes, and lymphocytes to that area. The leaked clotting proteins from the blood that came from the capillaries over here start to form that mesh, basically trying to seal off the area, prevent any further penetration in the system. Overall, all this plays together for healing of that injured site and prevent infection. From a clinical standpoint, what is the pest? It's a mixture of the dead or damaged cells. It's a mixture also of dead neutrophils, because they have to be removed, from phagocytosis, any of those dead pathogens, and there may be living pathogens in there. An abscess is when you've laid down your collagen fibers, walled off that area of pus that may need to be surgically drained. Some bacteria, they may be engulfed by the macrophages, but they aren't digested. They actually make a capsule within the cell, surround themselves, and they remain actually alive inside of the macrophage. An example of this is the bacteria that causes tuberculosis. It's one way that it's able to remain alive and for long periods of time and resist treatment. The problem from a microbiology standpoint with the bacteria that are able to resist digestion by the macrophage and remain alive inside the cell, it's hard for your immune system to see something that's inside your cell because it recognizes your cell as okay, it's part of you. It doesn't know the bacteria is in there, and then oftentimes they remain in like a dormant or an inactive state. But at a later time, they can become activated and release and then cause disease at a later time. These antimicrobial proteins that I have mentioned, they're going to be assisting in the whole defense. They can work different ways. They can work by actually attacking the microorganism directly, or they can interfere with the microorganism's ability to reproduce. So some of the most important ones are the complement proteins as well as the interferons, which I'll just let you know, depending on where you end up in the country, some people pronounce it interferons. So these interferons, there's several of them. Cells that are infected with viruses actually can secrete some of these interferons that then basically are warning other adjacent cells that are healthy, like, oh, careful, there's a virus and you be careful. The interferon will enter these adjacent cells, and then what they do is they stimulate production of certain proteins that will block the reproduction of viruses. So that if the virus does infect the adjacent cell, it cannot reproduce in it. Like I said, there are different types of interferons. There's interferon type alpha and beta. There's also ones that, in addition to preventing viruses from replicating in cells, they can also help to activate the NK cells. Those are the natural killer cells. And so this diagram is just showing how it is very effective in this defense mechanism for you. So here's the virus. It enters into your cell. It's going to take over the machinery of your cell. And what happens is these interferon genes are switched on. At this point, the cell is going to produce these interferon molecules. It's a chemical. It gets released. Now, meanwhile, the virus here it's making new virus particles, and those are going to eventually be released from the cell. Well, over here you've also released the interferons, which have gone into the adjacent cell. As I said, it's going to basically, it's like, hey, guess what's happening next door? We got this virus here, be on the lookout. And it produces chemicals so that when the virus does infect the cell, it's going to block the reproduction of the virus. Complement. This is a system which has multiple proteins involved. Usually they are in an inactive state. You don't need them all the time, so why have them active? We tend to number them using the letter C and then a number. The numbers, they don't go in order of how they're activated. It's the order in which they were discovered, just so you know that. Sometimes it's referred to as a cascade because what happens is when it becomes activated, these proteins of the complement system, some will bind together and then activate another protein, which activates another protein, which, anyway, it's this whole stepwise process. And the bottom line is it's going to destroy the foreign substance. It's going to destroy that pathogen. It also helps to enhance the inflammatory response, which, as you can see, that inflammatory response, we just talked about all the factors involved that help to fight the infection. So complement's going to be involved with both the innate, and we're going to also see it's also involved with the. It can be activated by 3 different ways. The classical pathway, which involves antibodies binding the lecithin pathway, and then there's an alternative pathway. And for the purpose of this class, no matter which way is activated, just know that each one of them, it is a very orderly sequence. It is dependent upon the step before it. If you have a block in any step, nothing beyond that is going to happen. What happens ultimately, regardless of which pathway it goes down, is that eventually it's going to enhance that inflammatory response. It's going to help promote phagocytosis and ultimately lead to the lysis of that foreign substance. So as you can see here, you've got the 3 different pathways. All 3 of them, you are going to end up with the stepwise process of the proteins have to bind in a particular order. Ultimately, what happens, like I say, it can enhance the inflammatory response. It can enhance what's known as opsonization. That's where it's going to coat the pathogen surface, and that enables or enhances phagocytosis. It's like putting a little flagging on it, if you will, and say, here it is, this is the foreign substance, so that those cells that carry out phagocytosis can recognize it and destroy it. What does the complement, the series of proteins also, what does it do? Here is the cell membrane. What the complement proteins will do is they form this structure, and it's like poking a hole into that membrane. It pokes it in there, and it's almost, if you want to think like a straw, it's kind of like the proteins all come together, they form this cylinder structure, and it's going to poke through the membrane of the pathogen, or whatever the foreign substance is. If you have a cell and you poke, say, a straw in it, what's going to happen to the inside of the cell, all those fluids? If you take a water balloon and you take a straw, and let's say you put a nail on the end or a pen on the end, and you poke it into a water balloon, what's going to happen to the water inside that balloon? It's all going to leak out through the hole in the straw, right? Well, the same thing's going to happen with the cell. When those complement proteins come in, they form the cylinder structure, as you can see around here. In the middle is a pore, an opening. So when this penetrates or pokes through the membrane, all the fluid inside the cell can now just come out that pore. Do you think the cell's going to survive that? No, it's going to kill it. That's lysis, that's the destruction. Another thing that can happen with the part of the second line defense is fever. Obviously, fever is higher than normal body temperature. It's a systemic response to the invading pathogens. Um, what happens is your leukocytes, those neutrophils, the macrophages are going to secrete what we call pyrogens. Pyrogens are going to act on the hypothalamus. Hypothalamus is what controls your internal body temperature. It's just like you walking up to your thermostat and raising the temperature. And that's what it's going to do. It's going to increase that set point. Now, a slight fever is good, because what that's going to do is in the liver and the spleen, it's going to have them sequester or hold the iron and zinc. Iron and zinc are both needed by microorganisms for survival. So if the liver and the spleen basically hang on to it, don't let it freely flow through the blood, then ultimately the microorganisms are going to die. Fever is also increased temperature, increases metabolic rate. That means it's going to increase the rate at which you can repair any of the damaged and injured tissues as well. So in this table, it is showing the second line of defense. So if something was able to penetrate, say, through the skin, now it has to deal with the second line of defense. The phagocytes, the inflammatory response, the fever, etc. And all of these, it doesn't matter what it is, the response is going to be the same. Now, the third line of defense, which is known as the adaptive defense or adaptive immune system, this is where it's very specific. It does make a difference as to what the organism is. It can recognize the difference between E. coli bacteria versus salmonella bacteria, etc. Part of the activities involved with this, it's going to amplify the inflammatory response. It's going to activate that complement that we just talked about. Now, there is a memory that is associated with this. So one of the drawbacks, they often talk about it must be primed, and that just means the first time you have been exposed to whatever the pathogen is, this priming takes a little bit of time so that the response will not be immediate as you activate the system. Now, any subsequent exposure, then it's immediate in terms of the response. But the first time you have been exposed to it, there's a lag delay on this. So like I say, it is very specific. It is systemic, so it's not going to be isolated as a response localized just to where the initial, say, entry point was. It's a systemic response. And then, like I said, it does have that memory response, so that on any subsequent response, you're going to have an immediate response, and it's much stronger than what that first response was. There are two branches or two subcomponents of the adaptive immune system. There is the humoral, which is also known as the antibody mediated, and then there's the cellular immunity. For the humoral immunity, this is going to be involving the production of antibodies. These antibodies can, once they're produced, are going to circulate in the blood, interstitial fluid, etc. They will bind to their target cell, to the antigen, that foreign substance, and it can inactivate it, and basically it's marking it when the antibody binds to the antigen, to that target cell, it's going to mark it for both complement and phagocytes for them to destroy it. Humoral immunity has extracellular targets. It's going to involve the B cells. Cellular immunity is going to involve the T cells. And in this case, the lymphocytes act as against those target cells. They can either directly kill infected cells, or indirectly they can release chemicals that are going to enhance your inflammatory response and activate other cells. Cellular immunity has cellular targets. Antigens, these are substances that are going to stimulate or provoke an immune response. It is a foreign substance. It is a marker. Oftentimes proteins make very good antigens that are on typically the surface of a foreign cell. So when you see antigens, think foreign substance. It's not part of you. It's something that's foreign that has penetrated into you. And that is what the adaptive immune response is going to be targeting against that. So this is non-self. Now, the characteristics of the antigen, they're going to contain certain components of it that are referred to as the antigenic determinants. Like I say, protein antigens. A complete antigen is going to have two different properties or functions too. It's going to be able to stimulate the proliferation of very specific lymphocytes. That's the immunogenicity of it. And the reactivity of it is its ability to react with the activated lymphocyte and the antibodies that may be released. Incomplete antigens are also called haptens. Basically, these are molecules that are too small, so by themselves, you're not going to see any type of immune response. Very small things like peptides, which are not as large as proteins, nucleotides, some hormones. Now, if the hapten attaches to something else, then it may trigger a response. All cells are covered, if you remember, with a lot of different proteins on their surface that extend out from the cell membrane. Now, you are able to recognize what belongs to you and what doesn't belong to you. So for you, these proteins that are on the surface, your body's not going to recognize them as an antigen. It's part of you. But if you were to donate, say, a kidney to someone else, it has your markers. Those now become antigens, and somebody else will recognize those as foreign and would attack them. Part of or a group of the proteins we call these are MHC proteins, major histocompatibility complex, and that's what's unique to each person. So mine are going to be different from yours, and that's how you can determine the self versus non-self. Now you have two types of lymphocytes, the B cells and the T cells. So the B cells are involved with the humoral immunity, T cells are with cellular immunity. Now there's another group of cells that are very, very important in helping to activate the adaptive immune system, and those are going to be what we call your APCs. These are your antigen presenting cells. So they're going to play a role in the beginning start process. Now in terms of the lymphocytes, at the very beginning of development, so lymphocytes or B and T cells, they share a common part at the beginning of development, and then later it changes. So the 5 general steps are the origin, maturation, seeding, antigen encounter, and activation, proliferation, differentiation. So both B cells and T cells, the precursors of them are going to originate in the red bone marrow. So that's going to be the origin. From maturing of these cells, the B cells are going to mature in the bone marrow, and then what happens to the cells that eventually become T cells, the precursors to them, are going to move from the bone marrow, they move in the blood to the thymus. And so T cells mature in the thymus, B cells mature in the bone marrow. Now, some of the original lymphocytes are going to leave the thymus and the bone marrow, and they are going to move to some of your secondary lymphoid organs. It's what we call seeding. So they're going to go to, an example would be the lymph node. When the lymphocytes, when they encounter an antigen, the lymphocyte becomes activated. So when they're exposed to the antigen, they become activated. And then once they have become activated, they are going to start multiplying. That's what proliferation is. And then they're going to differentiate into, some of them will be cells that are going to respond right now, and others will become memory cells. These memory cells and these effector T cells, they're going to be circulating in the blood, in the lymph, and throughout the secondary lymphoid. In the thymus, when you're looking at the T cells, positive selection versus negative selection, the T cells must be able to recognize that major histocompatibility complex that you have, the self one. So if they're able to recognize it, then basically those cells are going to survive, and the survivors proceed on to what we call negative selection. If they are not able to recognize your major MHC complex, then basically they're going to go through apoptosis, which is essentially cell suicide. Those cells are going to die. It's like, you didn't do what you're supposed to, you're not working properly, so we can't use you, and those are going to die. Negative selection is when the T cells, they must not be able to recognize the self-antigens. You want to be able to have these cells be able to recognize other antigens and not yours. If they recognize your antigen, then there'd be a problem that can lead to autoimmune diseases, and so those cells would also then be. A whole series here of how the cells are going to go through a maturation process. If it doesn't occur properly, then those cells will be destroyed. The genes determine which foreign substances the immune system is going to recognize, not the antigens. So there's literally thousands of gene codes. And so this way, it's very, very basically. To very generally summarize the B cells versus T cells, this table is showing what type of immune response they have. They compare whether they're producing antibodies, what their primary targets are, where they mature, etc. So it's just a quick summary of these. Now with B cell and the clonal selection of it, the primary response is when you have that first encounter with the antigen, which is shown as this little red structure here. That is the foreign substance, the antigen. And what happens is the antigen binds to a receptor on specific B lymphocyte. Now, the activated cells now, because they've been exposed to, are going to now activate the plasma cells. The plasma cells, in turn, are going to secrete antibodies. Now, some of these are also going to become memory B cells. So these will remain, and any future subsequent exposure to this exact same antigen that was up here, it will be able to trigger an immediate response and produce more antibodies at that time. Now, these antibodies that are produced by the plasma cells, which were triggered by the activated B cells, which were activated by the antigen, these antibodies can bind to this specific antigen. The antibodies are going to be floating or circulating in the blood, the body. And so this is just showing that memory cell, what happens with a secondary response, subsequent exposure to this antigen. This may be a few months later, it could be years later, and how you get this very strong immediate response. So the primary immune response, this proliferation and differentiation of the lymphocytes after they have been exposed to the antigen for the very first time, there's a lag period. It can last anywhere from 3 to 6 days. Your peak level of antibodies can be reached typically in about 10 days, very high levels, and then the antibodies levels are going to start to decline. With a secondary response to that exact same antigen, I said, you're going to have a very quick response. So those memory cells respond within hours, not days. The antibody peak, instead of 10 days, is going to be 2 to 3 days, much, much higher level. And it's going to be a stronger attraction between the antibodies and the antigen. And the antibody level can remain high for a very long period. So in this graph, you're just showing here is the first exposure to antigen A. Here's your primary response. As you can see, there's been this delay here. Here's your production of the antibodies. And then as you're fighting the infection, the level of antibodies is decreasing. You're feeling better. You're fine. Here is a second exposure to antigen A. Boom. Here's very strong response, high levels of antibodies being produced. You're exposed to something else that's different. This is just showing the specificity. It can distinguish between A and B. So now you start this whole process. Again, produce antibodies to B. It goes down. This explains why, as an example, I'll say influenza, the flu. You're exposed to a certain strain of the flu you've never seen before, you would be producing antibodies. That's helping you to fight the infection. You get better, levels go down. If you see that exact same strain of flu again, boom, you have an immediate response. You may not even know you're sick. You have protection against it. Why? Because you have those memory cells. Now, if you are exposed to a different strain, this shows, once again, the specificity. A different strain of the flu, it's enough different that the antibodies aren't going to recognize it. And so now you're going to start this whole response over against the second strain. That helps hopefully explain why every year you need to get the flu vaccine. You say, well, I got a flu vaccine last year. Won't it protect me this year? Only if it's the exact same strain of flu. And unfortunately, there's often mutations. And so there's several different strains of the flu that typically are out. Excuse me. So with immunity, with the humoral immunity, that production of the antibodies, this leads into, you can have active versus passive humoral immunity. Active is when you are actually going to make those antibodies yourself against whatever the pathogen is. Passive is where you are not making the antibodies, you're going to receive pre-made antibodies. It will still provide you with protection, but you are not making them yourself. If you do not make the antibodies yourself, that therefore means you do not have that memory component of it. So it's going to protect you right now, but years later, no, because you don't have the memory cells there. So this will provide short-term protection. Active immunity is going to provide short-term and long-term because you will have that memory component. Now within each of these, you have both naturally acquired and artificially acquired. So naturally acquired active immunity, this is when you were exposed to a pathogen, you actually had the infection. Maybe you actually had, let's say, chickenpox. You actually had the flu. You had the infection. You had contact with that pathogen, and so you ended up producing those antibodies. You ended up having those memory cells, so you should have also long-term protection. Artificially acquired means that you did not have direct contact with a living pathogen. You didn't acquire the infection. In this case, you had exposure artificially, and in other words, you received a vaccine. The vaccine is typically the way they do vaccines now. Years ago, sometimes they had living weakened pathogen. Attenuated means that it's weakened. They try to use now dead or subunits, so it's not even the whole pathogen, so there'd be no way of you contracting the disease. Either way, you receive the vaccine. So you are exposed to it. You do produce antibodies against it. That's the whole idea behind vaccine, is that you're activating your humoral immune system, so you're producing antibodies, and you do generate those memory cells so that any subsequent exposure, you will be protected from it. But you don't have to have the disease itself. Many of the vaccines that we have now are for diseases, most of your, what used to be called your childhood diseases. Some of these can be devastating, and so there's no reason why, certainly like a child, should have to suffer through some of these diseases. There's no reason why anyone should have to suffer through, say, polio. That can be absolutely devastating. So the vaccine is providing you with a safe way of being exposed to those pathogens and yet gaining protection against them. With the passive, what's happening here, like I said, is you are not producing antibodies. You're not being exposed to the pathogen, so you never produce antibodies. And also, like I said earlier, you don't have that memory, so you don't have that long-term protection. Naturally acquired is when the antibodies are being produced by a mother, and if she is nursing an infant, the antibodies are being passed through her breast milk to that nursing infant. Or if she is still pregnant, the antibodies can usually pass that placental barrier, and so they can protect the developing fetus. Like I said, it will protect short term. A newborn does not have a fully functioning immune system, so this is one way of protecting that developing that young newborn. Now, within a few months, the newborn's immune system starts working, and so they can start producing their own antibodies. But at this point, what happens? The mother is providing the antibodies to the infant. Artificially acquired passive immunity is when an individual is receiving antibodies that were produced by someone else, usually by injection. They will inject these purified antibodies, and this is once again going to provide protection right now. You don't produce your own antibodies. This may be done in a situation where you have these antibodies that are available and you have an individual who can, say, not receive a vaccine. Maybe they are immunocompromised. Maybe they're going through cancer treatments. They cannot get sick. Their immune system is already compromised. It's not working 100%. You cannot have them get sick. And so there may be an infection going around. So the best way to protect them is to give them antibodies that somebody else has made that will confer protection on them. Some vaccines, a lot of vaccines actually, are against viruses, which viruses are hard to grow. They need to have a host cell. And so a lot of vaccines actually are produced, they grow the cells initially in chicken eggs. And so if somebody has an allergy to chickens, they may not be able to receive that vaccine, which is one reason why before you receive a vaccine, they will usually ask you, are you allergic to eggs? That's why they're asking that, if you've ever wondered, because that's where the vaccine is produced by using chicken eggs. So if you're allergic to it and you can't get it, then you may need to, if there's an outbreak of a particular disease, you may need to then get these preformed antibodies injected to provide protection for you. The antibodies that are being produced are also called immunoglobulins. They are proteins. As I said, they're secreted by those plasma cells. There are 5 different groups or classes of them. We call them IG and then give them a number, or excuse me, a letter. The basic structure of the antibody, it kind of looks like a Y. There are 4 chains. You have 2 what we call heavy chains, and then we have 2 light chains. There is a constant region, and there's also a variable region. That variable region is what becomes specific for, at the very end, has an area called the antigen binding site. So that's where the specificity is on there. This is a general drawing of an antibody. Some people describe it as a T. I tend to describe it looking like a Y. These longer strands in the middle, as you can see, they're longer than the other ones. So these are the heavy chains. They're longer. They weigh more. The ends here are the lighter chains, or the smaller strands here. About halfway through right here on either side is where you have the division between the variable region and the constant region. So from this point down is the constant region on both the heavy and the light. And the end, so like the tips of the Y over here is where the variable region is. And this is where the specificity comes into play. The antigen binding site is right on the very edge, the very tip of the Y up here on either end. So that's where this is the antibody, and this is where the antigen would bind. So that's why it has to be very, very specific and recognizes the differences from one, say, protein to another. As I said, there's 5 different classes of these. IgM is in the shape of a pentamer, so it's like you have 5 of these that are connected together. This will be the first immunoglobulin that is secreted by the plasma cells when you have your first primary response. So this is the first one that's going to be seen. Usually it exists in that pentamer form. IgA is a dimer. You have 2 of these structures that are connected together. Sometimes it's referred to as a secretory immunoglobulin because it's found in body secretions such as in your saliva and milk and sweat. This will only exist for a limited amount of time. In the IgD is a monomer, just a single structure. It's found on the surface of B cells. It can function similar to IgM. IgG is the most abundant of these antibodies. Most of them are in this form. It is going to be seen as the secondary. So initially you have the IgM numbers really high, and then it's going to switch, the IgG numbers become very high. So mid to late in the response, and certainly also in secondary responses, you're going to have the IgG immunoglobulin seen. And then the IgE, which is also a monomer, it's a little bit longer than the others. It can bind to mast cells and basophils. It's usually only small amounts. This is seen, though, with oftentimes parasitic infections and also with allergies. So the antibodies are not going to destroy the antigen. They're just going to bind to them and then activate them and form this complex, antigen-antibody complex. And then there are going to be other types of reactions or processes that occur because of this. So up here you have your antigen. Here's the antibody. When they bind together, you form this antigen-antibody complex. Now it can be inactivated by a couple different ways. It may be neutralized. Oftentimes if it's a toxin, this will neutralize it. If it's viruses, it can sometimes neutralize them. Agglutination and precipitation is when they bind and form these complexes. The difference between them, agglutination is with insoluble or cell-bound antigens. Precipitation is with soluble antigens. All three of these, when the antibody binds to that antigen, it's going to enhance phagocytosis. So your natural killer cells, your phagocytes, like the macrophages, etc., they can see this complex much more readily now. It's like it's flagging it, and so that's going to trigger phagocytosis. Now, it can also what we call fix and activate the complement system. So here it has bound to, the antibody has bound to the antigen on the surface of this particular organism, and now that activates the whole complement cascade process that we've talked about previously, which results with the complement protein forming, boom, embedding in the wall of the foreign cell. And remember, it forms that pore. What does that lead to? Cell lysis of that particular cell, because all the fluid is leaking out. It is also going to complement, remember, itself is going to enhance phagocytosis as well as enhance the inflammatory response, which leads more phagocytic cells to the area just to help further increase this whole defense mechanism, which is protection for you. Parasitic infections by worms often require a different type of attack strategy because the worm's too large for phagocytosis to occur. So what happens is IgA antibodies tend to bind to the worm, the surface of the worm, and then it marks it for destruction by the eosinophils. Several eosinophils are going to bind to the IgEs that are bound to the worm, and then they start to release toxic components into that prey, basically destroying it from the inside out. Monoclonal antibodies are used often as research tools as well as clinical tools. Basically, what monoclonal antibodies are these commercially prepared pure antibodies for a very specific antigen. They are produced by cells that are known as hybridomas, which is basically where you've taken a B cell and fused it with a tumor cell, allowed it to grow. This tumor cell allows it to grow indefinitely. Most cells have a limited time that they can grow, but the tumor cells, the regulatory process has been turned off, so they grow indefinitely. The B cell portion of it allows it to produce that very specific antibody. So you can use now that for research, for clinical testing, and they're looking at this in terms of cancer treatment. Once again, that antibody-antigen complex does not destroy the antigen. It just prepares it for destruction by the innate defenses. So this is how they work together. Antibodies tend to go after extracellular pathogens. Usually they're not going to be destroying viruses, only if the virus is recognized before it enters the cell. There have to be other mechanisms to destroy the virus once it has entered. T cells are going to provide defense against those intracellular antigens. So they can provide a means of attacking cells that now are infected with the virus or infected with bacteria. They can also recognize cancerous cells or abnormal cells, and these are the ones that are going to recognize any type of foreign cell, like if you've had organ transplant. Sometimes the cells are going to directly kill this, the infected cell. Other times they will release chemicals that are involved. So once again, remember both B and T cells start out in the red bone marrow, and then that immature lymphocyte is going to move to the thymus where it matures. It will mature either into a CD4 cell or a CD8 cell. CD4 cells, these cells, excuse me, are going to become activated by antigen-presenting cells or dendritic cells. Dendritic cells are a type of antigen-presenting cell. Now, in this case, the class 2 major histocompatibility complex protein is being displayed. What has happened is the antigen-presenting cell has engulfed a foreign cell. It recognized something foreign and engulfed it, and it is displaying certain markers. Part of the antigen is it engulfs the cell internally, but then part of the antigen it exposes on the surface, and that's what is now being used to activate the CD4 cell, which is now going to go through the proliferation state or the reproductive state. These CD4 cells down here will ultimately become either what we call helper T cells or regulatory T cells. Some of the CD4 cells will become memory cells. Now on this side you have the class 1 major histocompatibility complex. Once again, it's being displayed over here by this antigen presenting cell, activating these cells, which become the CD8 cells. Some of them will become memory cells, and the remainder are going to go through reproduction, and these will become cytotoxic T cells. And these are going to be moving into the lymphoid tissue as well as into the blood plasma. Now the T cells are only going to respond, like I say, not to the entire foreign substance, just to a piece of it, of the antigen that's displayed on the surface along with that MHC complex. So there's class 1 and class 2. The class 1 MHC proteins are displayed on all cells except for the red blood cells, and the class 2 MHC proteins are displayed by the antigen-presenting cells, your dendritic cells, macrophages, and B cells. So both of them are synthesized and will bind to these fragments. So this is comparing the class 1 versus the class 2. What they are recognized either by the CD8 or versus CD4, and recognizing, is it part of you or is it not part of you? So those T cells, like I said, become activated when that antigen is presented to them by the antigen presenting cell. It's a couple-step process. You're going to have to make the memory cells as well as the T cells. So as we just said earlier, here is the antigen presentation by the antigen presenting cell. You have this recognition that has to occur, and then you form what we call the clonal formation. Some of these will become memory cells, and then the rest of them from CD4, they will become the helper T cells. The CD8 those cells will become the cytotoxic T cells. Now the helper T cells, they're going to play a huge role in activation because they tend to activate, helper T cells are going to activate additional T cells. There are multiple T cells. So when the CD4 activates the helper T cells are going to help activate the regulatory T cells, which are involved with helping to prevent autoimmune diseases. They kind of help keep the cytotoxic T cells in check. The helper T cells are also going to play a role in helping to stimulate or enhance the stimulation of the cytotoxic T cells. The helper T cells are also going to help activate B cells. So once that antigen presenting cell has engulfed the foreign substance, it presents the antigen, activating the helper T cells, and activates the CD4 cells, which become the helper T cells. If you do not activate the helper T cells, you're not going to have any immune response. And just so you know, the one thing that the HIV virus does is that it interferes or inhibits the CD4 cells. If it inhibits the CD4 cells, then that means you never activate the helper T cells. If you never activate the helper T cells, you can never activate the remaining T cells, those regulatory and cytotoxic ones, and in turn, you also never activate the B cells. If you never activate the B cells, you don't even have a humoral response. And if you don't activate those helper T cells, you're not going to have a cell-mediated response either. Bottom line is, you don't have an immune system. That is one of the reasons why, left untreated, the HIV virus will is the causative agent of AIDS, which basically is a breakdown of your entire immune system. And how does it do it? Knock out the one that's supposed to fight you. It's a rather clever way from terms of the virus. You want to infect a host. A virus has to have a host cell in order to reproduce. It cannot reproduce without a host. So from the virus standpoint is you want to reproduce. You don't want that host cell recognizing you and attacking you and destroying you. So how do you protect yourself? Knock out the immune system. Knock out that whole surveillance system. And that's the cytotoxic T cells. They're going to be derived from the CD8 cells, which are there is activation there from the helper T cells. These are going to, as the name implies, cytotoxic. These are going to directly attack and kill other cells. So once they have been activated, they're going to circulate in the blood and the lymph. They're searching for any cell that has that antigen fragment on it. When it recognizes it, it's going to destroy it. So they're going to target virus-infected cells. They're going to target cells that have intracellular bacteria or parasites. They're going to target cancer cells and any type of foreign cells, such as from transplants. So the cytotoxic T cells can kill these other cells by two mechanisms. They release perforins and granzymes. What happens here is the perforins start to create pores, and the cell that's unfortunate enough to come in contact with those cytotoxic T cells, it's going to release those perforins. They create a pore, and then granzymes are going to move in through that pore and basically trigger apoptosis, once again, a cell death. So it's the cell's going to lyse. Also, the cytotoxic T cells have specific receptors on the target cell that can also the cell suicide, if you will. So here is the cytotoxic T cell. Here's a target cell. Ooh, it recognizes the that it's a foreign cell. And what's going to happen is, so it recognizes, it's going to bind to it very tightly. It is going to release these porphyrins. They look like these little tabs. Forms this porphyrin pore, this hole, which inside now the granzymes can come in, and boom, it is going to trigger basically cell death. And it's destroying the prey. It's the way of destruction there. Those regulatory T cells that I mentioned a little bit earlier, as the name implies, it's helping to regulate the cytotoxic T cells. It can help to kind of modify that immune response or tone it down a bit by secreting cytokines that are inhibitory. It's involved with helping to prevent autoimmune reactions. Only attack foreign cells, not your own cells. So this diagram is showing kind of a summary. Here is the antigen, that foreign substance. You have your innate defense. Number one, can it get past that surface barrier? Can it penetrate through the skin? Ooh, it did. Now you've got your internal defense systems. You have the inflammatory response. You've got fever being generated. The release of some of the chemicals from the damaged tissue that are attracting phagocytes to the area. If they don't get it, you're now also turn on the adaptive defense, the specific one, which is going to be the cell-mediated where you have your antigen presenting cells have engulfed that foreign substance. They present the antigen on the surface. You now activate your CD8 cells. You activate your CD4 cells. This is going to be huge right here, the CD4 cells, which then give rise to your helper T cells. Some of these become memory cells, so if you ever see this again in the future, you'll have a very immediate response. Those helper T cells, what are they going to do? In turn, they're going to now also help activate the CD8 cells, which give rise to the cytotoxic T cells, which are going to bind and basically kill the offending cells because they're out searching for this. You also have memory cells here, so if you ever see it in the future, here are those helper T cells. They're also releasing cytokines, which are going to help stimulate some of your macrophages, the natural killer cells. The helper T cells also are going to now activate the B cells, which some of those become memory cells, and then also that will activate the plasma cells to produce the antibodies, which are specific, once again, against this antigen. When they bind to it, what happens here? That helps to attract complement, which is from, remember, the internal defense here, to carry out cell death. So you see how, number one, all of this is going to work for your protection, but the cellular immunity, which involves the T cells, the humoral immunity, which involves the B cells, they work together. How? Even though some of them are working extracellular, some are working intracellular cells, the activation of the T cells ultimately will activate B cells, and they're going to work together. And the adaptive defense is also going to be working with your innate defenses. If something can penetrate past this first line of defense, you've got the second line of defense and the third line of defense. Remember, the innate is very non-specific. This is going to happen no matter what the specific organism is. The adaptive defense is very, very specific. And this table is showing some of the different cells and some of the different molecules that are involved with the immune response. Essentially, when you see complement, think cell lysis. With organ transplants, how do you prevent rejection? Basically, what is going to happen, because the patient who receives that organ transplant, their immune system would recognize the markers on the donated organ as foreign, and so it will stimulate the entire adaptive immune response and attack and destroy those cells. Obviously, you don't want that to happen. And so what happens is, number one, when there's going to be an organ transplant, for it to be successful, you want the tissues to be of those organs between the recipient and the donor to be as similar as possible. So obviously, number one, you have to have the same blood type. There are over 30 different markers on blood when we do typing, and you want those. Usually we just look at the ABO for blood transfusion, but for an organ transplant, you're going to want to match those antigens up as closely as possible. The more closely, the more similar they are, the better chance of you having success. The recipient, the patient, is going to have to be treated with immunosuppressive therapy. They have to take medication to suppress their immune system. Why? Because you have to suppress those T cells, those B cells. You have to suppress the entire adaptive immune system so that it will not recognize that new organ as something foreign. How long do you have to take these drugs, immunosuppressive drugs? You must take them for the rest of your life, because as soon as you stop, your immune system will kick in. Does this mean that your immune system is suppressed? Yes, it is. You have to do that in order for the transplant to be successful. The drawback of this is that, yes, that means that you are going to be more susceptible to anything that is around you. So any type of infection, you're going to be much more susceptible to. You'll be more susceptible to the flu, to common colds, etc. Some of these therapies have additional effects, but there really is no other choice. If you are at the point that you need to have a transplant, there's no other options left for you. um, so these other infections is the leading cause of death amongst transplant recipients because their immune system is suppressed. Different types of immune problems. There are different types of immunodeficiencies. This may either be congenital or acquired throughout your lifetime where there has been some impairment. Severe combined immunodeficiency syndrome is where there's a genetic defect and it's affecting both the B and the T cells. What is the treatment? If you can do a bone marrow transplant, because that's where the B and T cells originate from, that would be the best form. Hodgkin's disease is an acquired immunodeficiency, causes cancer of the B cells. It tends to depress the lymph node cells, which then leads to immunodeficiency. The lymph nodes are depressed, they're not working properly, they're not able to have that surveillance to catch any foreign substances that may be traveling through the lymph. AIDS, which is acquired immunodeficiency syndrome. The causative agent of this is the HIV virus, the human immunodeficiency virus. As I said earlier, the virus interferes with the helper T cells, which, as we see, are so vital and critical in activating the rest of the T cells as well as the B cells. Typically, this is going to be characterized in the AIDS and severe. There's a progression of stages of the AIDS. So towards the end, in the severe stages, it's characterized by very severe weight loss, night sweats, swollen lymph nodes. You tend to see opportunistic infections occurring because the immune system is wiped out. The virus itself can be transmitted by bodily fluids and blood, semen, vaginal secretions. The HIV virus tends to multiply in the lymph nodes. It can remain, a person can be asymptomatic for years left untreated. Symptoms usually don't begin until the immune system starts to collapse. There is no cure for AIDS at this point in time. There are a combination of drugs that can be given in a cocktail, what we call a cocktail, because it's a combination of drugs that can help. Basically, kind of delay it can, but it's not a cure. It can certainly help in the treatment, but over time, concern is whether the virus becomes resistant to those drugs. So it's not a cure. There are other types of autoimmune diseases. Basically, what's happening with any autoimmune disease, the immune system now no longer distinguishes between self and non-self. And so it starts to attack everything. There are several different examples of autoimmune diseases. RA, or rheumatoid arthritis, tends to just start to destroy the joints. MS destroys the white matter along the myelin sheath. Graves' disease causes hyperthyroidism. Type 1 diabetes mellitus starts to destroy cells within the pancreas. What is the treatment of autoimmune diseases? You can give anti-inflammatory drugs that starts to suppress the entire immune system. There is research ongoing trying to see if there's some way of activating the regulatory T cells, but this is an area of ongoing. Nothing's confirmed yet. Hypersensitivities. This is where the immune response basically it's overactive. It responds in such a way that ends up causing more damage than if it had done nothing at all. And there's different types of hypersensitivities. We distinguish them by the time and whether antibodies or T cells are involved. T cells tend to involve a delayed type of hypersensitivity. Excuse me. And so basically you end up oftentimes with the release of histamine, and this ends up with a huge outpouring of fluid from the capillaries because of increased permeability. You tend to have increase in mucus and oftentimes constriction, such as in the bronchioles. And so what a person sees is possibly asthma, increase in mucus, may end up with like sneezing, the increased permeability of capillaries. Hypersensitivities, there's 4 different types. Immediate hypersensitivity, this is also called type 1 or acute hypersensitivity. This deals with allergies. It usually starts seconds after contact with that allergen. It's the antigen that is causing the allergic reaction. The first initial contact is usually asymptomatic, but basically what it's doing, it sensitizes the person. And then any subsequent or later encounter with that exact same allergen, what has happened the initial times that activates the IgEs. So with initial or later encounters, that same antigen is going to, with the IgGs, is going to cause a release of the histamine from those IgEs. And that induces an inflammatory response. The histamine causes vasodilation, causes leakiness in the vessels. What the patient sees is a runny nose, oftentimes watery eyes. They might have hives that become very itchy. If you've inhaled the allergen, you may have asthma due to constriction of the bronchioles. Because there's this histamine that's being released that's causing all the problems, that's why you take an antihistamine to help control it. The allergic reaction could be local or it could be systemic. When it's local, that's oftentimes where you might see redness or hives in a particular area. But either way, you need to take control it. If it's a systemic response, this can lead to anaphylactic shock. In this case, what can happen is the bronchioles can constrict. This makes breathing very difficult. This is oftentimes what you see when somebody has an allergy, say, to peanuts or to bee stings. And with the vasodilation that's occurring, the blood volume tends to go down because you have basically leaky capillaries, and this leads to collapse of the circulatory system. It can be fatal. So treatment needs to be immediate, and you treat with epinephrine, which causes vasoconstriction. So it helps to reduce that loss of blood volume. But like I say, this is where treatment needs to be immediate to prevent anaphylactic shock. This is for individuals who know that they have an allergy to, say, bee sting, where they get the systemic response. They need to carry an epi pen with them, and that's where you inject the epinephrine. Subacute hypersensitivities. This is where in the blood, the plasma, you have transference of IgM and IgG. The onset can be relatively slow, take 1 to 3 hours for it to start. It can be, duration be very long. This is what we call cytotoxic 2 reactions. An example of this is when the wrong type of blood is given in a blood transfusion. Type 3 hypersensitivity is immune complex. An example of this is where you have the antigen is distributed widely throughout the blood or in the body. You form these antigen antibody complexes that are insoluble. They cannot be cleared from the particular area of the body where they form. You end up with intense inflammation. An example of this would be systemic lupus, which is a type of lupus. Delayed hypersensitivities, which is the fourth type of hypersensitivity. This has a very slow onset. It can be 1 to 3 days after being exposed. It depends on helper T cells. Basically, an example of this would be like exposure to poison ivy. And another example would be TB10 test, depends on this type of reaction. In terms of developmental aspects of the immune system, the stem cells start to develop in the liver and then the spleen between weeks 1 and 9 after fertilization has occurred. And the stem cells later in the bone marrow become the primary source of the immune cells, and then throughout the adult life. The lymphocyte development, as you know, is going to continue in the bone marrow and the thymus. Different things that can have an influence on the immune system function, the nervous system, things like depression, if you're under a lot of emotional stress, if you're under a lot of grief, these can all kind of suppress or impair the immune system. Diet plays a role in terms of vitamin D is necessary for activation of the CD8 cells, which activate the cytotoxic T cells. So a deficiency in vitamin D can have an adverse effect on the immune system. As we age, it seems like everything tends to slow down. There tends to be increased susceptibility to autoimmune diseases as we age and immunodeficiency diseases as we age. There also seems to be a greater increase or incidence of cancer as we age. Why the immune system tends to fail as we get older, we don't really know. We do know that the thymus atrophy and gets smaller as we age, and there's a decrease in production of those immature T and B cells, so that may play a role as well.